everyone.
Dr. Murali Krishnan will take you first. Dr. Sanket.
Thank you, sir. So, good evening, everyone. I am Dr. Sanket Nevale, representing Medical Affairs at MCure Pharmaceuticals. Welcome, everyone, on this unique platform called No Thrombosis Workshop Series in Acute Ischemic Stroke. We have today meeting for the 7th episode of this, and we have our course director, Dr. Nasli Ichapuria, sir, and the moderators today would be Dr. Anshu Rohadgi, sir, and Dr. Arvind Sharma, sir. So without any further ado, I would like to introduce and take this pleasure to introduce my course director for tonight would be Dr. Nasli Ichapuria, sir. Sir is a director neurology at Sahyadri Hospital, Pune. First Neuro ICU and Neuro Intensive Care of Pune. He has been a pioneer in thrombolysis treatment for stroke in India. More than 300 public lectures and workshops on stroke. Member of the Indian Stroke Association and the organizing president of StrokeCon 2012. The organizing president of ISA Stroke School. Ex-president of the Society of Neurosciences, Pune, and ex-president of Maharashtra Academy of Neurology and founder of the Pune Stroke Group. Principal investigator for multinational stroke trials like PERFORM in stroke, BG12 in MS, and cortical venous thrombosis, BrainsGate in stroke, Interact 2 in cerebral edge. Recently awarded as the health icon by the Times of India Group. Sir, we welcome you for the event.
Thank you so much.
We have our moderator today, Dr. Anshu Rohadgi, sir. Sir is a consultant neurologist and professor of neurology at Sir Gangaram Hospital, New Delhi. Secretary, Delhi Neurological Association 2021 onwards. Joint Secretary, Association of Neurologists in Clinical Research, Mumbai. Coordinator for the National Accreditation Board of Hospitals and International Organization of Standardization for Neurology. Principal investigator in more than 24 studies like VitaTop, Profess, etc. Over 47 publications in various reputed national and international journals. Presented more than 25 scientific papers at various conferences, guest faculty at many prestigious national neurological meetings and conferences. Sir, we welcome you for the event.
Thank you, Sanket. Thank you.
We have our moderator today, Dr. Arvind Sharma, sir. Sir is the head Department of Neurology, senior consultant neurologist, stroke specialist, and neurosonologist at Zydus Hospitals, Ahmedabad. Honorary Associate Professor Neurology, BJ Medical College and Civil Hospital, Ahmedabad. Secretary of the Indian Stroke Association. President, ANBAI, Gujarat. Founder, member, and treasurer, Society of Neurosonology. Executive member of Academy of Neurologists of Ahmedabad. Executive member and treasurer of Indian Stroke Association 2018 to 2020. Publications in national and international publications in peer-reviewed scientific journals. Honors and awards like the Best Poster Award, AOCCN, April 2009 in Seoul, South Korea. McKinney Award, American Society of Neurology 2011 in Florida, US. Travel Award at Asia Pacific Stroke Conference in Japan. And Travel Award at European Stroke Organization in Sweden. Sir, we welcome you for the event.
Thank you.
We have our expert speaker today, Dr. Shrikant Londe, sir. Sir is a consultant and in charge of the Interventional Neuroradiology Unit at Noble Hospital, Pune. Renowned neurointerventionalist in Pune. He has done his MD from JIPMER and fellowship in the neurovascular intervention from CMC Vellore. He has a total of 7 years of post-fellowship experience, has contributed to an ICMR IACI guidelines for imaging in acute ischemic stroke 2021. His area of interest lies in ischemic stroke imaging and interventions. We have our second speaker today, Dr. Murali Krishna Konda. Sir is a consultant neurologist at BBR Super Speciality Hospital, Hyderabad. He has an excellent academic record with the winner of the Tropicon 2022 quiz in 2022. Received Professor P.V. Chalapati Rao Memorial Merit Award, and many Best Poster Awards in various national conferences. Area of interest lies in stroke, tropical neurology, and multiple sclerosis. Sir, we welcome you for the event. And with this, now I hand over the session to our course director, Dr. Nasli Ichapuria, sir, for his opening remarks and context setting. Over to you, sir.
Thank you so much. It's a great pleasure for me to welcome all the illustrious persons here. Anshu is a great friend, and he's got many accolades to his credit. And of course, Arvind Sharma, he's ever energetic, ever friendly, and ever helpful person that I've ever known. And he's always smiling, and he never raises his voice, and he's an absolutely wonderful person. So thank you, Arvind, for being there, and thank you, Anshu, for being the co-moderators. And of course, we have our very talented young speakers, Dr. Shrikant Londe from Pune and Dr. Murali Krishnan from Hyderabad. So, we've had, this is the 7th program in the series, and I think we've had amazingly good discussions and, small points in stroke thrombolysis. And I think many people have appreciated this program. So it'll be very open, and we will discuss it, every case threadbare, and please take part, ask me as many questions as possible. And I'm sure our moderators, both of whom are extremely talented, will be able to help you to improve stroke care in the country. So I now welcome the doctor. First, I would, of course, like Dr. Anshul to say a few words. Anshu?
Thank you, sir. Thank you, Dr. Ichapuria. Thanks for inviting us to take part in this stroke updates and series. I think it will be very interesting to listen to a person. One of them is a neurointerventionist, another is a neurologist. So I think, and every day we are faced with a new challenge in stroke. Every day we have a new challenge, and stroke is a very difficult. Sometimes it makes life so difficult at times. But I think we are all learning. We're still everybody is still on the learning curve. There is nobody can say that I am the master of stroke. So I think we are all, as we go ahead, we are learning newer and newer things. And I think we can maybe take more messages from there, learn something new. So I think it will be a good exercise both for everybody here.
Arvind?
Thank you, sir. Thank you very much. And we all follow your passion for stroke, and thank you for inviting us for this session. And I definitely agree with my co-moderator, Dr. Anshu, that we are all eagerly waiting for a wonderful session here about the no thrombosis. And it is a learning on all the parts, never that we're going to teach. We'll also learn, and we'll discuss thread by thread, as you said. Thank you.
Thank you so much. Dr. Murali Krishnan, could you start your case?
Yes. Is it visible, sir?
Nothing of so far.
No.
Nothing.
Nothing, sir?
No, we cannot see anything. Nothing changed. Are you using the share screen button?
1 minute, sir. Okay. Now,
Yeah. Yeah. It just started. You can get into full mode now. Perfect. Yes. Over to you, sir.
thank you. So, good evening, sir. It is my pleasure to present the case in front of the senior stroke specialist. My case is totally different case. I'll see the response from the audience also, because finally you may ask whether it is stroke or not, why you presented here. Okay. Thank you. So my story is like a PG presentation. She is a 54-year-old lady presented with a resident of Hyderabad. She is studied up to BA second year. She presented with the chief complaints of change in behavior since 1.5 years. So previously, her background was like she used to wake up early in the morning and used to manage household costs efficiently. She was an ardent devotee, used to do puja like classical Orthodox Hindu lady, worshipping of specific deities and day wise, that is on Monday, like Lord Shiva till Saturday and Lord Balaji. And she used to fast for 3 days in a week. She used to monitor maids, servants, household work. In between, she used to spend time by talking and chatting in the phone with her two sisters, son, daughter, and reading newspapers, magazines, solving puzzles. Totally, she was a live wire in control of her household. But she presented with behavioral changes since 1.5 years. So after history, so finally, without any without any vascular risk factors, with 1.5 year duration of insidious onset, gradually progressive behavioral changes in the form of apathy, inertia, and loss of empathy, with executive dysfunction, with some features of disinhibition and language dysfunction, with relative preservation of visual spatial functions, without any significant motor, sensory, cerebellar, or autonomic dysfunction. That's why I told this is not an acute presentation of stroke, but so this is the routine analysis for the PGs. So she presented with apathy, inertia, which are localized to medial prefrontal cortex, whereas diminished social interest, interrelations, decline in social cognition is ventral part of the medial prefrontal cortex. Difficulty in planning, task setting, set shifting, sustaining, and stopping the task. These are all suggestive of executive dysfunction, dorsolateral prefrontal cortex. Loss of empathy is frontoinsular. Urinary incontinence with loss of self-care, decorum, these all are disinhibition, again orbitofrontal cortex. Language dysfunction is again frontotemporal involvement. So classically, it seemed to be a cognitive case. So we thought of these are the differential diagnoses: behavioral variant, frontotemporal dementia, and frontal variant, and secondary causes. And after examination, with some features of disinhibition and loss of reading, writing associated with impairment in memory calculations also we found. So these all are routine workup, all routine workup, including the CBC as well as TSH, vitamin B12, ANIF, CSF, and vasculitis workup, all are normal. So clinically, it is a behavioral variant frontotemporal dementia. But the imaging, these are the diffusion weighted images from the axial images. You can see there are few diffusion restrictions here and there in the frontal lobes, in the parietal lobes, the periventricular region, even in the splenium of the corpus callosum, with even ADC mismatch also. So by seeing these diffusion restrictions, outside physician, general practitioner started on aspirin, and she came to us, aspirin and valproate. She came to us with the complaints of weight gain with the valproate. And the thing is, these are the other images. These are the T1 and T2 weighted axial images from the caudal to cranial. You can see there is atrophy predominantly in the frontal regions as well as in the parietal region. And we can see in the T2 images, the periventricular hyperintensities. These are periventricular hyperintensities, and even in the splenium of the corpus callosum. These flare T2 hyperintensities also seen in even the these T2 hyperintensities predominantly involving the subcortical frontal lobes as well as parietal lobes. But if you see, they are typically sparing these U fibers. So, and we can see, and these are the sagittal images. We can see the flare hyperintensities in the subcortical regions. There is a lot of cortical atrophy as well as the thinning of the corpus callosum also. Their hyperintensities are there even in the corpus callosum also. So with this picture, and this is the angio images. So angio showing normal caliber of the anterior and posterior cerebral circulation. So this is a picture that they have started on actually aspirin and as well as valproate. But after seeing these diffusion restrictions along with this T2 flare hyperintensities in the subcortical regions, these diffusion restrictions, we can see they are not following any typical arterial territory. They are here and there everywhere, almost in the subcortical regions. They are not following any arterial territory. You may ask, they may be embolic shower also. But the crux is here the thing. The T2 and flare hyperintensities typically involving the periventricular regions, splenium of the corpus callosum, and they are sparing typically the U fibers of the cortex. So by seeing this, we thought of something else and we went to the neuroradiologist. And neuroradiologist suggested that these diffusion restrictions are very typically seen in along with this T2 flare hyperintensities in the periventricular region with sparing and with cortical atrophy. He suggested this is leukoencephalopathy. And this leukoencephalopathy with diffusion restrictions only seen in two conditions. One is HDLS, hereditary diffuse leukoencephalopathy with spheroids. Another is ARS2. So by seeing this, so we requested the genetist for the whole genome exome sequencing. Our DDs are HDLS, hereditary diffuse leukoencephalopathy with spheroids, and ARS2, alanine transfer tRNA synthetase 2 mutations, and vanishing white matter disease. So these are our three first differential diagnoses. And finally, we found our first differential was positive. And we found a mutation, heterozygous pathogenic mutation in the exon 14 of the chromosome 1. This is an autosomal dominant disorder, which is called as leukoencephalopathy, diffuse leukoencephalopathy with axonal spheroids and pigmented glia. So these mutations these are due to colony stimulating factor 1 receptor gene. This colony stimulating factor 1 plays a predominant role in the microglial scavenging function of the brain. So this is exclusively seen in the adults, most cases occurring in patients between 20 to 50 years of age group. The clinical pictures is behavioral changes, dementia, motor impairment, including extrapyramidal and pyramidal manifestations. And the MRI typically suggestive of punctate areas of diffusion restriction in the early phases of the disease. They are termed as deep white matter diffusion dots, and their appearance may even mimic CNS vasculitis. And these diffusion restrictions will be persistent forever. If you do after 2 years, if you do after 3 years, these diffusion restrictions will be persistent. And there will be thinning of the corpus callosum also along with the calcifications. So this is a case report from Canada, Janice Wang. So their case also presented like frontotemporal dementia and finally turned out to be HDLS. So I want to tell one thing, that all diffusions are not strokes. Clinical presentation, detailed evaluation, including examination and correlation of imaging findings are important for correct diagnosis. Thank you. Sir?
Anshu? Anshu, would you like to say something? Arvind?
Yeah, definitely. Thank you for the presentation, Murali Krishna. So I have two questions to you. First of all, you said that every diffusion restriction is not to be considered as a stroke, right? I agreed that part, right? There are different images. That is the imaging question. But how at any point of time, without MRI, on clinical history, you suspected any vasculitis or thrombosis in this patient? Means we are, in any point of time you thought of stroke when you are giving the clinical history or examination?
We didn't, sir. We didn't. Actually, we thought of frontotemporal dementia only.
So I have another question. Why not a gradually progressive nature of the staging methods of vascular dementia? Why you have not considered that part of if it can be a vascular nature for the dementia?
Sir, clinically, it is frontotemporal dementia. I agree. But after seeing the imaging, after seeing those diffusion restrictions and the clinically typical sparing of U fibers, so then we thought of dysmyelination, leukoencephalopathy. Without imaging, everyone say this is a frontotemporal dementia. Some cognition case.
Yeah. Dr. Anshu?
No, I think it's a very, very interesting case, very unusual presentation of I think so. I think he has given us the idea if you have a patient, similar patient, and if you have the imaging findings, which what he has described, then we would definitely. This is a very rare diagnosis. I have never seen or such a class. So very interesting. But as far as treatment is concerned, can we do anything for these patients?
Sir, there are two case reports of stem cell transplantation.
Mm-hmm.
After stem cell transplantation, there is no reversal, but there is not even progression also. One case is there since last 14 years. They've been following in the US. So the stem cell transplantation is under the way, sir.
Because whenever we have a patient with dementia, we're always looking for a treatable cause.
Yeah, yes.
So I think that for us, I think that is the takeaway message should be that whenever you have a patient where you are suspecting a frontotemporal, I think imaging becomes important, and especially if you have a good radiologist who can see a diffusion restriction. I think that the message was basically leukoencephalopathy, sparing of U fibers, and diffusion restrictions. I think these three things will help us in making a diagnosis.
Yes, sir.
I think it's a very, very, very nice case, very, very interesting. Of course, it is not a typical stroke case that we would expect.
Yeah.
But definitely a good case to diagnose.
Thank you, sir. Yeah.
So, can I ask a question? Yeah. So, what were your differential when you have seen the imaging? You have done these tests. What were your differential at that time in your mind after seeing the image?
Immediately when we are discussing, sir, this case was discussed in the patient management meeting. Immediately, I think our consultant was there at that time, another consultant. He rose that why there are so many diffusion restrictions which are not following any specific arterial territory. And there are so many, even splenium of the corpus callosum is involved with, and T2 flare hyperintensities are there in the subcortical regions. So then there with a lot of atrophy, initially we thought of dementia only, but after going to the radiologist, neuroradiologist, he has given the clue. We thought of just, okay, there is a small vessel ischemic changes also we thought of.
Yeah, I must congratulate the radiologist. Yes, because, he hit the diagnosis straight off.
Yes, sir.
I wouldn't have been able to diagnose this case. I was thinking all along that it's some type of vasculitis. And though there was no headache, there was no inflammatory markers.
Yeah.
So, looking at those pictures, could you tell us what are the causes of diffusion restriction besides ischemic stroke?
Abscess, demyelination, sometimes even tumors also. Especially
abscess. Yes, sir. but that is a single thing, diffuse like that. Why is there diffusion restriction in this case with this genetic profile?
Diffusion restriction suggestive of there is ongoing, the water is unable to.
Yeah, but is it an infarct in these cases? Why the diffusion restriction in this particular entity?
The diffusion restriction is suggestive of some cell deaths there, but I cannot say that it is infarct.
Yeah. Suppose you had done a biopsy, what would you have found?
Yes, sir. Biopsy typically that suggestive of axonal swelling, and that axonal swellings will be called as spheroids, and they will be pigmentation also. This pigmentation will be staining for specific kind of molecules. That's why they are named it as axonal spheroids, diffuse leukoencephalopathy with axonal spheroids.
Yeah. So, the genetic test has really clinched the diagnosis. Otherwise, we would have just gone round and round and would not have been able to make, or maybe we would have done a brain biopsy. And even then, maybe the pathologist could have told us. But this genetic test really has been a major advance, because without that, I don't think we could have diagnosed this case.
Radiologist
what do you think?
Given the clue, sir. Radiologist only given the clue.
Yeah, I must congratulate him. I mean, it's a fantastic diagnosis. Anshu, what do you think?
Absolutely, sir. I think it's a very, very difficult to, we would have thought of a small vessel disease. And
yeah.
I think and it's really, really commendable. I think your radiologist is really good. Lucky to have him.
Yes, sir. Yes, sir. Thank you, sir.
Yeah.
At present, this patient is in US, sir. They went for some options of stem cell transplantation. They are exploring all the options there. Sunny's is there in the US.
Okay.
So they have taken there.
Yeah. Amazing case. Great. I don't think I'll be able to diagnose it. Next time such a case comes, I'll keep my antenna up. But
I think once in a lifetime case.
Yeah. Okay. Arvind, do you want to say something?
Thank you, sir. I agree. Definitely. It's a good learning point that not all diffusions are stroke, and but we would have evaluated for stroke if that genetic workup was not done. I agree with that.
Yes.
Yeah. I would have gone all out to diagnose stroke in this one.
Yeah.
And then maybe we didn't have such a good radiologist, but I think we would have gone round and round. And I don't know. There's no family history. You said it was heterozygous. So what is it? Autosomal dominant? What is it?
Dominant, sir. Dominant.
So any family history you got or anything like that?
No, sir. No, not it, sir.
So it was just a mutation, or is it a large family and you could, trace somebody with the disease in the past? And what happens? What is the prognosis?
Prognosis is obviously, sir, leukoencephalopathy, slowly progressive and dismal prognosis.
Achha, so it goes downhill rapidly.
Yeah, not rapidly, sir, but it is going down. Now she started eating bottle caps, whatever the things available, like environmental dependency is there.
Yeah. So, clinically, we would have diagnosed it as a frontotemporal dementia and just let it go. But I don't know if it is treatable. Maybe stem cell. We don't know. We don't know. It's so rare. So, how can you do any study? Or, it's all anecdotal. It'll have to be anecdotal, You can't do a study on this case, So, it will be anecdotal.
Now, after seeing this, my colleagues diagnosed another 2 cases in the last 1 year.
Oh, wonderful.
Means there are so many cases we've been ignoring.
Maybe. No doubt about that. Maybe. See, the more you see these things, only then. Otherwise, I don't think I would have been able to diagnose this one. Impossible. So good that you showed this case. And thank you so much.
Thank you, sir.
Arvind, anything you want to say further? Or shall we go to the next case?
We can move further.
Yeah. Yes, sir. Yeah, thank you, Dr. Murali Krishnan. Thank you. I think next time we will, if we get a case like this, thank you for enlightening us, because once you see it, I think we should not forget it. So, though it's not a typical stroke case and this is a stroke meeting, but still we are neurologists, and I think such patients will come to us.
Yes.
And it's good to know these things. And thank you so very much.
Thank you.
Yeah. Dr. Shrikant?
Yes, sir.
Yeah. Can you start?
Yes, sir. I'll just share my screen.
Yeah.
So, very good evening all, and I thank for the opportunity to present, to get an opportunity to present a case in front of stroke leaders of India. And after an amazing case by Dr. Murali, my case is quite simple. So I'll start with the case details. So 30-year-old male patient with the sudden onset right-sided weakness and aphasia. So this particular patient actually is working in IT sector, staying with the roommate, and roommate left in the early morning, and nobody was able to contact the patient till the evening, and the house owner was called in and he broke the door, and they found that the patient is not able to wake up. And when they woke up the patient, he was having the right-sided weakness with aphasia. So they reached to our center. The last well-known was almost 16 hours from the well-known symptom that he spoke to his relatives. He is a non-smoker, non-alcoholic, no family history of the stroke, non-diabetic patient, no history of hypertension, and normal BMI. So fairly young age patient with active lifestyle. So he presented to our hospital at around 8 o'clock. And when he presented, his admission NHS was 20. So we went ahead with the imaging. On the imaging, what we could found on CT brain, plain CT brain, we can see there is a definitive hypodensity in the region of the lentiform nucleus, as well as the area of the coronary radiator on the left side. So we did a CT angiogram. On CT angiogram, what we can see is there is the absence of the opacification of the left terminal IC and as well as MCA. So there is a thrombosis, possible thrombosis involving left terminal IC as well as the MCA, and patient has a fairly good collateral in the later phases. So the information we get is a small core of the infarct, and we are having a large deficit in terms of the NIHS 20 and the proximal large vessel occlusion. So around 8:30 we finished the imaging, and since patient presented almost after 18 hours, 16 to 18 hours of last well known, he was out of window for IVT. Unfortunately, our MR was not working that day, so we could not do the MRI diffusion and the flare images to just get an idea about the any mismatch, what could be the time of onset and everything. But we were sure that somebody from the close relative, they told that they spoke to the patient over phone 16 hours back. We thought that patient is out of window for the IVT. This case was discussed with our team in detail. And since clinical and imaging mismatch was there, decision was to intervene with the mechanical thrombectomy. It was taken at 9 o'clock. So these are the initial images. So left internal carotid angiogram. What we can see here is there is no opacification of the terminal IC as well as the intracranial branches, with otherwise should be like this. This is the AP projection and the lateral projection. So we can see the ophthalmic artery and the PCOM. Beyond that part, nothing is seen. So it should have been seen like this in the normal patient. So we know the level of occlusion. So straight away, we went ahead with the crossing of the occlusion level. Wire went very smoothly. And when we placed the stent as well as the aspiration catheter here, we did not get anything. But this was the result after the first pass. So what we could see here, there is a mild irregularity with the filling defect in the region of the terminal ICA. This is the MCA and the superior and the inferior division. So definitely there is a narrowing, but we could not get any clot either in the stent retriever or the aspiration catheter. I waited for 5 minutes. There was a progressive occlusion of the stenosis. So here itself, I thought that patient has no risk factors at all. He is a fairly healthy adult, and there is a progressive occlusion at the level of the progressive occlusion even after opening at the first pass. So I could be dealing with either intracranial atherosclerosis or intracranial dissection. So this patient was not loaded with any antiplatelet. I just gave the aspirin to him and took the patient for thrombectomy. So IV tirofiban bolus was started by the infusion. The next thing what I thought is, since patient is not having any risk factor, I just thought that we'll just deploy the stent and see how is the flow pattern distal to the level of the occlusion. So we did something known as a stentoplasty. I deliberately avoided balloon angioplasty because if it is intracranial dissection and if you are inflating the balloon in already damaged intima, there is a high chance that vessel might rupture. And this patient should be loaded with antiplatelets, IV tirofiban. So it's quite a high risk actually to do a balloon angioplasty. So what I thought is, the same stent retriever I will keep for some time, and for 5 to 10 minutes I will check. So after removal of the stent retriever, this was the final angiogram. Again, we can see there is a definitive narrowing as well as the multiple filling defects, 1 or 2. So IV tirofiban was given, waited for 30 minutes, and then control angiogram showed the similar finding. Another after 5 minutes, what we can see is the definitive narrowing, concentric narrowing in the region of the same segment. So finally, the decision for the rescue stenting was taken, and these are the images after the rescue stenting. So stent was placed. Now we can see the terminal ICA, MCA superior and the inferior division, and these are the lateral projection. We can compare with the AP pre as well as the lateral. So after what I did is I gave the aspirin as well as the IV tirofiban bolus followed by the infusion for this patient for 24 hours. And we repeated the CT after 24 hours. So these are the CT images. So on CT, what we can see in this patient is a mild cortical SH is there. The SH pattern is actually extending till the sylvian fissure also, superior part, and there are hypodensities inside the brain. So here, one thing is, when you do the rescue stenting, we should know that when you are doing multiple maneuvers like putting the stent across the stenotic segment and pulling that stent along with the aspiration catheter, sometimes what happens is there will be a shear injury to the blood vessels, especially the intradural branches, and this shear injury can manifest in terms of the SH. But if you are sure that control angiogram is not showing any active extravasation during the procedure, then we know that the cause for SH in this patient is probably the shear injury happened during the procedure, and there is no need to worry actually. In spite of SH, we continued with the IV tirofiban infusion as well as the aspirin for 48 hours, and then we changed the tablet aspirin and the Plavix. So this patient did a remarkable recovery actually. Next 2 days, he showed complete recovery in terms of the weakness of upper and lower limb. Speech, since the opercular area and the speech area, everything was involved. He had a partial recovery at the time of discharge with persistent anomia, and he's on regular speech therapy. So he was discharged from our hospital in 7 days. This was the photo after discharge. So what are the points to remember? That in resistant occlusion at the intracranial level, in young patient possibly, we're dealing with either intracranial atherosclerotic disease or intracranial dissection. So if you see the risk factor fairly, you will get a good idea about atherosclerotic disease or the dissection. Another thing is look at the vessels in general on CT angiogram or the DSA. If other vessels are also affected in terms of the narrowing or some atherosclerotic plaque in intracranial location, then probably we are dealing with intracranial atherosclerosis. If there is a high suspicion of the intracranial dissection, we can avoid the balloon angioplasty. And intracranial dissection, as we have seen in this image, the flap, that the dissection flap can be spiral actually. So we might get a typical concentric stenosis like an intracranial atherosclerosis. So these are the factors. Unfortunately, based on the CT or MRI, we cannot identify intracranial dissection with so much confidence as compared to the extracranial dissection like in carotid or the vertebral artery. So we have to rely heavily on the risk factors, angiographic findings in the way you are getting the response during the procedure. Regarding the dual antiplatelet medication, we have to consider whether IV thrombolysis was given to the patient or no IV thrombolysis. So we have to understand all the due risk. So definitely all of us are going to get the bad cases, and we have to learn from that how to deal, whether my patient is already thrombolized or not thrombolized. These are the two articles that I will highly recommend, because we have seen that we just follow the cardiology protocol for the neuro procedures. People are giving blindly the intra-arterial dosages for the tirofiban during the rescue stenting procedure. But this is the article from the China where they have demonstrated that intra-arterial tirofiban versus intravenous tirofiban as an adjuvant to the endovascular thrombectomy has shown intra-arterial therapy a very high hemorrhagic risk and the death rate. So the best treatment probably if you are going for the rescue stenting is to start on intravenous tirofiban rather than an intra-arterial, giving directly into the ICA. So this patient also, after going to this article, I got an insight about the dosages, protocol and everything. And all the drugs, they have a latent period of action. Tirofiban is 30 minutes. We should not rush giving more dosages, like whatever has been mentioned in the literature more than that, because definitely these are cases which you are intervening after certain hours actually. So there is a damage to the blood-brain barrier, and if you are giving too much lytics, too much antiplatelet, heparin and everything, definitely we are going to have a bad cases. So definitely if bad cases you are coming across a single case, you can go through the literature, prepare your own protocol and try to avoid all these complications. So these are points to remember based on this case. I will just share one case interestingly recently done at our center. So this young patient, again, a recurrent TIN, finally had a minor stroke, and outside CT angiography showed a narrowing. Sorry, this is the MR angiography picture. So he was about to get admitted for the DSA. Another time he had a minor stroke. Then we did a CT angiography followed by the DSA. So this patient has something known as a carotid web, very unusual and rare finding. No risk factors for any atherosclerotic. So carotid web is nothing but the congenital intraluminal intimal infolding. And here on this angiography itself, we can see the pathogenesis. There will be the stasis of the contrast, stasis of the blood inside this pocket, and the stasis of the blood leads to the formation of the embolism, leading to the intracranial circulation. These are the 3D MIP images showing the intraluminal projection of the web, and the treatment is straightforward. Either you go for the surgical excision of the web, or we can put a stent to oppose the web to the intima, whichever is available, so that there won't be any further stasis. Yes, thank you very much, sir.
Thank you, Dr. Srikanth.
Thank you, Dr. Srikanth. Thank you very much. Wonderful case, both the cases.
Thank you, sir.
So, Dr. Chapuria, can I ask the question?
Yeah, of course.
Yeah. So now the question comes. Let's see. I'm sitting in the one of the national conference for intervention here, right? And there was a debate about the aspiration and the stent retriever. So there was a hybrid also. What you follow, you are a neurointerventionist, right?
Yes, sir. Yes,
so
sir.
what you follow in your practice, while you are doing the, you directly go for a stent retriever, or you go first for a aspiration, Solembre, how you go further with the procedure?
Yes, sir. So actually, sir, we know that the nature of the blood clot is difficult to predict on the imaging or anything, and mostly we're dealing with the mixed clots here. So my first approach always to go with the combined strategy. I use the distal aspiration, proximal aspiration, and the stent retriever as a first pass. If I'm not getting the clot in the first pass, definitely I would revise. I will go back to the stent retriever strategy at least for 2 times. And if the clot is refractory for stent retriever, then I know we're dealing with, or either we have removed the red component of the clot and we're dealing with the white blood clot here. So I change it to the aspiration, only aspiration strategy. So that is my usual strategy.
Okay. And how much in the patients you have seen that, as you told that in Indian settings or in the South Asian settings, the ICAD has to be ruled out as it's a LVO picture, right? The way you have tried the case. So how many, you did the rescue stenting also. So do you have found anything like the complications of the thrombectomy, having the dissection while the procedure? How you feel that, how many you have seen or has happened?
Yes, sir. So almost I can say out of 100 cases, I would say close to 8 to 9 rescue stenting in intracranial atherosclerotic diseases or the ICAD. And almost these rescue stenting procedure, they have a very high complication rate because these are not recommended procedure. We are just doing because patient is bad and there is nothing else to be done. If you follow the protocol, like first few cases, I have seen that the reperfusion bleed or the stent getting occluded in initial 24 to 48 hours is quite high because we don't have a standard protocol what to follow in dual antiplatelet regimen after thrombolysis or without thrombolysis, whether to use heparin during the procedure or not. So all these issues were not clear, like in 2017-18. But after that, 2018-19, if we go through all the papers in Journal of Neurointerventional Surgery or the Stroke AHA, they have mentioned quite well protocol, especially in our scenario like East Asian, Chinese paper. There are papers from the Korea where they have given quite elaborative protocols what to do and what not to do. If we follow that, at least for last 6 to 7 cases, I have not seen any complication. But unfortunately, compared to native thrombectomy without any intracranial occlusion or anything, these cases definitely have a very high risk where even during the stenting, we need a very high guiding position, guiding catheter position. Even that also leads to the intracranial dissection by the guiding. So iatrogenic complications are also more, as well as the post-operative complications are also more.
Okay.
Dr. Anshu?
Yeah, I think we are also using the intravenous protocol. We are not using the interarterial, and we are getting, I think, good result with the intravenous. We are not using the interarterial. So you were initially using interarterial?
Yes, sir. Yes, sir. So initially, when I was in training, the initial concept was whenever we do aneurysm coilings or carotid stenting and some clot is happening, we just give intra-local. We think that the local dosages are less and there is like an early effect, less complications. So we used to give the intra-arterial part. But for the stroke, I have gone through all the papers where you have European data, you have American data, then we have our own data from the Asian countries. And there are many papers who have suggested that the intravenous bolus as well as the infusion therapy is much more safer and act as a similar efficacy protocol as compared to the intra-arterial.
Yeah.
So that is the reason that I have changed totally now to the IV rather than giving through the guiding into the internal carotid artery.
I think we are here using all intravenous and we are getting reasonably good results. Okay, interesting case. I think so. What is your protocol like at your center? What protocol do you do for patients who are beyond this, like up till 24 hours? What protocol are you following?
Sir, at our center, if patient present in initial 6 hours is a classical CT brain with CT angiogram, and if the patient presents after 6 hours, 6 to 24 hour, or in posterior circulation sudden worsening after any onset of the stroke, we generally do a CT brain with CT angiogram and the MRI DWI. So at least I will get an idea about the core, which is based on the DWI. And then I get an idea about the collaterals as well as the level of occlusion. Then we discuss with our stroke team member, neurology colleagues, what is the clinical picture, whether this patient will benefit from the intervention or not. And then we take a combined decision to go ahead with the thrombectomy. So this is my protocol. I generally don't go ahead with the perfusion. On CT perfusion, you need additional contrast, and the values which are coming through the perfusion, they are not that much reliable to take a decision. On MR perfusion is totally a different ballgame. Like you need a lot more time, and we don't know actually. We can't. My personal this thing is during my fellowship training, this was a perfusion was the most common imaging modality after few hours of the stroke. But I feel that we are just wasting time discussing on the values of perfusion. We have the clinical details and we have the core. We can easily take decision based on that.
Are you also using the rapid software on CT angio?
No, sir. No, sir.
Okay.
No, but Shrikant,
yes,
what
sir.
you have done is excellent.
Yes, sir.
Because you have shown that, it was a very low aspect score.
Yes.
And there was a gross clinical radiological mismatch.
Yes,
I mean, aspect score was very good, I would say, not
Yes.
low. Sorry. Aspect score was very good. There was no cortical involvement. There was little bit of basal ganglia hypodensity. And there was and that is what the Dawn trial has shown. That
Yes.
means you don't need to do an MRI.
Yes.
I mean, if you show this the clinical radiological mismatch and you show a large vessel occlusion, that's enough for you to take up the patient for thrombectomy. So I was very happy to see that, because, you know, you did not use very highly sophisticated things. You just used a CT angio, and it was extremely effective.
Yes, sir.
So that was really very nice. And tell me one thing, I didn't get that point clearly. You did not do thrombectomy, no? There was no thrombus.
Yes, sir. Yes, sir. So
You did not do thrombectomy.
yes, sir. First pass was done, and we did not get a clot. So
That means first pass with what did you do?
both stent retriever and the aspiration catheter combined.
Okay.
So when we examine the stent retriever as well as the aspiration catheter, we did not
Okay.
get any thrombus. So that is one of the
Okay.
clue to that you are dealing with an intracranial dissection probably.
Okay. Now, did he have any trauma or anything? How does this intracranial dissection occur, and why does it occur?
So generally, sir, like if you go by embryology, it is most commonly located like in terminal ICA into the MCA, because this is a relatively new segment of the artery which develops as compared to the anterocerebral or the ICA, which is below the PCOM artery. And most probably they say that compared to extracranial dissection, where we can get a history of trauma, blunt trauma, or anything like that, intracranial dissection is basically mostly an shear injury. So we may not get an direct history of trauma or anything. Only possibility we can get is a history of headache in some
Headache.
patients.
Yeah,
Yes.
so I was thinking headache. Did he have a headache retrospectively?
No, sir. Actually, I asked his colleague who was staying with him since many years actually. So I asked, there was no history of headache or anything, but he was little bit out of the work for last 3 to 4 days, and he didn't tell that what he was having and everything. But he had taken the leave from the work, maybe feeling of uneasiness or all those things he told.
Yeah. No, I was very, very impressed with your management of this case. And, you know, you were thinking on your feet and thinking in the cath lab what to do. It's always very difficult. So, and then you opened up the vessel beautifully. You achieved TK3, you said?
Yes, sir. This case.
I missed that picture, perhaps, of TK3. Okay, whatever it is. So you said that he had a mild speech disturbance only.
Yes.
Yeah, and the infarct post-op was basically in the deep white matter.
Yes, sir.
So mostly it was not a cortical aphasia; it was a subcortical aphasia.
Yes, sir.
Yeah. So it was the penetrating vessels which were involved, and the distal MCA and all, because of the good collaterals, was spared. Is that correct?
Yes, sir. Exactly, sir.
Yeah. So actually, you know, if you ask me, with this CT scan which you showed, that's enough for you to intervene. I mean, you shouldn't waste time doing diffusion and flare and this and that and perfusion. I mean, you're spending so much time in that. It would be more worthwhile, you know, you find the large vessel occlusion, you find that the core is small already, the aspect score is good. Straight away, you can take this fellow up for intervention. I mean, that is my view. I don't know. Arvind, Anshu, what do you think?
Sir, in our place, we normally follow the MR. We use an MR based protocol. So,
I know most people in India are using an MR based protocol.
We are using an MR based protocol.
Yeah, so, but you know, what we find is it wastes time, and many times patient is restless and we can't do it. So we have to sedate the patient, and it takes much more time. So but he has shown, Shrikant has shown
You know,
very
he's
beautifully.
shown that's a wonderful.
He has shown it very beautifully.
Very well, very
I
well.
must say, I was very, very happy to see that, because, you know, it's done in 5 minutes. It's just done in 5 minutes. You do the CT angio, 5 minutes, you see the collaterals, you see the core, you see the clinical radiological mismatch, and you've seen the collateral score. You have seen that the vessel is occluded, and that's all the information you need. I mean, doing this, that, according to me, it wastes a lot of time. Arvind, what do you think?
Yeah, I agree. Let's recap the things which Shrikant also mentioned very well about doing the things like less than 6 hours. As such, you don't need any perfusion or any other study, right? If you see the vessels. Even after that, if you have a good CT angio with the multi-phase CT, you can see the collaterals and you can decide upon. The main interesting thing in this case was, which he mentioned in the first line, is it a ICAD oblique versus a dissection? I am still want to find out the etiology for this patient, because it looks like that in Indian and the South Asian settings, the ICAD is very common, right? So is it was a dissection, or when he did the first pass, it was a ICAD? Shrikant will be a better person to answer this, that other vessels, how the other vessels were, and need to investigate for the mechanism of stroke in this case, right? Intracranial rescue stenting, and what is the scenario of intracranial stenting as such also. If there are recurrent TIAs and if you find such long stenosis and a small strokes happening again and again, even after the aggressive medical management. These are the 2-3 questions, Shrikant, if you can enlighten us.
Yes, sir. So if we go literature wise, sir, like how to identify the intracranial dissection in a patient of stroke. So what they say is, during thrombectomy, if you don't get any thrombus, then that is the first sign. Then the second sign is, if we get the extracranial dissection, we have a flame-shaped dissection. Actually, we know that flame sign is there. In intracranial dissection, we have that spiral type of dissection. So it generally comes as an concentric narrowing compared to the eccentric narrowing what we get in extracranial dissection. Then possibly you have a history of headache in those patients, or underlying risk factors are there, or vascular, any collagen vascular disease or this thing. So, and if you get other angiographic, like left contralateral ICA, vertebral, basilar, all these vessels are absolutely normal on CT angiography or DSA. This particular patient, I did a DSA actually after thrombectomy, even though CT angio was there, and there was absolutely nothing on the intracranial circulation. There was not even a single evidence. So
and no distal clot also. You may have thrown up the clot further, means you did the aspiration, I know that, right? And then the stent retriever. So it is not possibility that you have seen the check angio that there was no distal any occlusion further, right?
Nothing, sir. Nothing, sir. I have this post-operative image.
It's highly intracranial dissection without any headache, right? So that was the red flag for this case. Yeah.
We don't know whether he had a headache. That's the issue.
Yeah.
But this is always a problem, Arvind. I thought I'm struggling with this, whether it is really, and how to diagnose intracranial dissection, you know. It's always a little difficult, you know. At least I'm finding it difficult. I don't know about others, but I'm finding it very difficult to diagnose.
But, Dr. Nestle, but he mentioned one thing very right, that if the first pass is not showing any clot and it is coming through and through, then that part has to be thought of, no doubt in that.
Yes.
So what in your normal practice, Shrikant, you do stenting for ICAD, you manage with the aggressive, this was the acute one, I agree, right? Dissection type. But what about the ICAD? You have you stented any ICAD?
Regarding ICAD, sir, I am little bit of a conservative guy. So in my practice, actually, we start on dual antiplatelet. If the patient is again having TI or the recurrent strokes, in spite of that, we change clopidogrel to newer generation antiplatelet, or sometimes we go with the anticoagulation practice. In spite of everything, only they are sure like they are having recurrent TIA. In my practice, I use vessel wall MRI imaging also more oftenly. And once after MRI, as well as the patient history and the medication history, and I'm sure that patient was compliant to the medication, then only I go ahead with the stenting. Straight away after the first episode, or just based on the angiographic or the CT angiogram images, it is showing 90% stenosis. I generally don't prefer stenting.
Agreed.
Yeah, another important point, Shrikant, you mentioned these drugs, but very important, and we don't do it often enough, is lifestyle modification.
Yes.
And we don't emphasize to the patient, and it's not easy. I'm telling you, it's not easy to change lifestyle. It's okay, stop smoking and stop excessive drinking, but to do weight reduction, to do physical activity every day with a trainer, which was done in the Sampras trial, all these things are neglected by us. Then targeted cholesterol reduction to less than 70, these things are not done often enough by us. And that includes me. So, it's very difficult to, it's easy to give drugs and it's easy to monitor the cholesterol and to get the BP down and to give dual antiplatelet and all that stuff. But this lifestyle changes, I find very difficult. This weight reduction and doing physical activity daily. So what is your view, Arvind and Anshu? Do you find it difficult to do all these things? Or
I think, sir, I think we as neurologists are not doing enough. I think the cardiologists are very, very aggressive in this.
We don't have the stroke rehabilitation. This after bypass or after putting stent, there is this cardiac rehabilitation. But we don't have the stroke rehabilitation to prevent stroke. We have stroke rehabilitation after hemiplegia has occurred. But preventive stroke neurology, preventive stroke neurology is lacking.
Yeah, absolutely.
Arvind, what do you think?
Yeah, I totally agree. I totally agree with that part. And that is why the concept of stroke prevention clinic should come in picture in India, right? And across world, where the primary prevention, as we neglect below, above neck, we miss everything, right? We ask for a health checkup for a echo. We ask for a health checkup for doing the TMT even, but never seen any health checkups doing a carotid vertebral Doppler. To see the risk, how the IMT is, right? So those are the things which are to be seen. Even the intracranially, we don't see our vessels, because one of our colleagues having an intracranial stenosis and suffered a minor stroke. If you have done the imaging, as the Southeast Asians are doing the imaging to see the intracranial part, to know about your vessels, right? It is very important.
Yeah, so this is another area where, we, and Arvind, you are in a position now to start this, because you hold a very responsible and coveted position in the Indian Stroke Association. So perhaps, we, on World Stroke Day and all, this preventive neurology, or what do we call it? Preventive stroke management, I think we should re-emphasize. Everything, as you said, is below the neck.
Exactly.
They do exercise to look good and to get your heart rate up and to have good cardiac fitness. Anyone talks about brain fitness? Nobody talks about brain fitness.
Agreed, sir.
But I think for quality of life and to live well, I think brain fitness is more important than cardiac fitness. Of course, cardiac is important, no doubt.
But
brain fitness, nobody's talking about brain fitness.
Yeah, I think we take our brain as granted, vision, everything granted. We are not looking after, absolutely, because we are not talking about actually importance of sleep for impairing, for maintaining.
See, now even in this intracranial stenosis, we don't ask for disordered sleep breathing.
Absolutely.
OSA. So many people have OSA. My God, you just do that sleep study and you'll find so many people have OSA. And another risk factor which I'm thinking in Shrikant's case, these techies, they somehow we are seeing a lot of techies having stroke in young. I don't know what it is. Either they smoke or they drink or they are sedentary or they have too much stress or they don't sleep or they do night duties. I don't know what it is, but in their 20s and 30s, all these software people, or not all, many software people in their 20s and 30s are getting stroke and bad stroke.
I think it's.
I don't know if that is your experience also.
I think it's a
Arvind,
lifestyle.
Yeah.
I think lifestyle. They have a very bad lifestyle.
Yes,
very bad lifestyle.
Murli, you are in Hyderabad, so in Hyderabad also all this tech capital of India. Do you see all these chaps, young fellows getting stroke?
Yes, very frequently, and they have these classical vascular risk factors at an early age.
Yes,
diabetes.
So they are all occurring in their 20s and 30s, and it's not 50, 60, 70, 80. It is 20, 30. And many of these, really bad strokes, M1 occlusions, M2 occlusions, they are occurring in 20s and 30s. I mean, in fact, we in our group, we've got more patients in their 20s and 30s with MC occlusion than older people. I don't know what your experience is, but that is our experience. Anyone would like to comment? Arvind?
Yeah, very true. The way the risk factors are nowadays in the younger people, the genetic workup, the way the things are coming up, and the lifestyle. Specifically, the first two things which are should be on the top 5 is hypertension. They don't see their blood pressure and the smoking. These are the 2 factors I think which are the most important for the young stroke.
I think, another thing which we are not talking about is pollution, because already now you're smoking 10 cigarettes per day. If you're living in an urban area, and Delhi, I think you're smoking 20 cigarettes a day.
Absolutely.
So pollution is like smoking. It's as big a risk factor as this thing.
Absolutely.
So, this is also affecting. And I don't know, these technology people, they don't go out in the sun. They are indoors. They are sitting all the time. So something is happening and it's become an epidemic. And, this chap was also 38. Now, whether he had dissection or ICAD, we don't know. But we are seeing many in their 20s and 30s with intracranial large vessel occlusions.
And I think we should be more aggressive in finding the mechanism. We should not stop after treating and get happy that patient has been fine.
Correct.
We are seeing, as Dr. Nestle, you have seen a lot of patients after the stroke coming with an MI. And after the MI, they are coming with the stroke. And this is what the common phenomena is in the patients.
Yes. So that's a very important point, Arvind. We must investigate the heart. We must look at the aorta. We must do TE. We must do long range holters, at least 7 days, if not more. So we must look a little more deep into these cases. We are very happy we've removed the clot from M1. Fellow is fine. He's got a little aphasia, but he's walking, moving. So we just, and he spent a lot of money. So now we are also lulled into, he's done so well. But we forget that, you have to do a holter, you have to do a TE, you have to look at the aorta, you have to do these things. And these things we must do. So very important.
Absolutely.
Yeah. Any other points? Dr. Murli, do you want to say something about this case?
No, sir.
Shrikant, any last words?
Nothing, sir. Absolutely true. Whatever you say, sir. Like stroke etiology workup is something, and preventive stroke workup, that the stroke risk modification is something that we should look for.
Yeah, closing remarks from Anshu and Arvind.
think we had a very good discussion today, and I think we saw one very rare case, and another one is that we should look out for dissection. There's not always a clot there, and I think in both the cases were very, very different. It's a good learning experience.
Arvind?
Yeah, no, fantastic cases. And first was an eye-opener that I was thinking about stroke all the time, right? As it is no thrombosis. And it turned out to be the way I thought. We'll go for a vasculitis workup, then we'll think about. And the second case, I still request Shrikant that he should go further to know the cause of it, right? We are still inquisitive to know what the prognosis for such patients are, because as Dr. Ichapuria mentioned and Dr. Anshul mentioned, that for young stroke, the etiology is very important, and the quality of life further, that patient should not succumb further for another stroke. So mechanism of stroke is very important. And thank you. Wonderful company of the moderator and the course director. Thank you.
Thank you, Dr. Arvind.
Thank you, everyone. I think we've had a wonderful evening. And Sanket, I'm sure you agree that we had a wonderful evening. Ajinkya, you also agree?
Yes, sir.
You are here for the first time.
Yes, sir.
So
sir, there
Sanket,
are
how many people attended?
So there are more than 100 people. So our usual is more than 200, but then this time is more than 100. I've been asking my field as to what happened and where, and so they are following up, sir. However, the 2 points that I noticed, or I have noticed during this meeting, which I held myself back because the discussion went in so rich. So as that, first and foremost, you reminded me of the Three Idiots, where the hero says, pressure यहाँ पे दिल पे मालूम है, but यहाँ पे कितना है नहीं पता. There is no unit to measure it. And the second part is like where you said any final comments, and the last time Dr. Meenakshi Sundaram was like, I don't want to give any final comments. I would want to come back more and over in these kind of meetings. So with that note, sir, I want to introduce Dr. Ajinkya Nanavare, sir, who would be taking care of these meetings in the coming future. Sir, I'll always be there, but it would be Dr. Nanavare who would going to be taking care from here in onwards. So final vote of thanks, I would invite Dr. Nanavare to give the vote of thanks. Over to you, Dr. Nanavare.
Thank you so much, Dr. Sanket. It was a wonderful workshop. So first of all, I would like to thank Dr. Murali Krishna sir and Dr. Shrikant sir for presenting those interesting cases. And also, thank you so much, Dr. Ichapuria sir and Dr. Anshu sir, and also Dr. Sharma sir for your expert comments and great practical insights. We would like to work under your guidance for many such future programs, sir. So with this note, we will close this session, and thank you everyone again. Bye. Good night. Have a happy weekend.
Good night, sir. Thank
Bye,
you.
sir.
Good night. Good night. Thank you.
Good night, sir. Good
Thank you.
night.
Good night.
Thank